Good afternoon, everybody. Welcome to today's Antibiotic Stewardship Echo Clinic. Thanks for joining us today. We'll start up, as we usually do, through Echo with introductions of everyone. So I'll kick us off. Troy Jorgensen, I am the Program Manager for Project Echo. Go ahead, Charlie.
Charlie Krasner, Infectious Diseases at Renown and University.
I'm Jessica Thompson. I'm one of the infectious diseases pharmacists at Renown.
I'm Marshall. I'm one of the PGY2 pharmacy residents in infectious diseases at Renown.
I'm Esther Zhang. I'm another infectious diseases pharmacy resident.
I'm Mike Stander, retired infectious disease pharmacy.
Golf player.
That's my primary.
Keo Mahajer, infectious disease pharmacist at Renown.
Jennifer Hipskin, PGY1 pharmacy resident at Renown.
I'm Marilyn Tucker. I'm an MSN student, nurse educator track.
Excellent. All right, and we'll go out to our audience now then. So a couple folks joining us at Mountain Grant General Hospital. Could you please introduce yourself?
I'm Nori Chan from Mount Grant General Hospital.
And who's that joining you?
I'm Kathy Verkamp. I'm the risk manager at Mount Grant General Hospital.
Great. Thanks, Kathy. Good to have you. Dr. Van Gelder, go ahead.
Hi, I'm family medicine out here in Lovelock, Nevada.
Thanks, Dr. Van Gelder. Anna Marie. Go ahead, Anna. I took you off mute. We should be able to hear you.
There you go. So I'm Anna Marie White, and I'm in Fayetteville, Arkansas. I work at the VA, and I'm in primary care.
Excellent. Great to have you today. Steve, please go ahead.
Yep, Steve Poley, working in Jasper, Texas, and LMU student.
Third time's a charm. Great.
Thanks. Good to have you. Hannah?
Hi, I'm Hannah Winders. I'm actually in South Carolina with the Antimicrobial Stewardship Collaborative of South Carolina, just trying to watch because we're planning on starting our own Stewardship Echo.
Are you a pharmacist?
I am.
Oh, thanks for joining.
This was the first Echo Antibiotic Stewardship Program. We started this in 2012.
Yep. Yep.
Awesome. Hope to learn a lot.
Thanks. Willem, are you there?
I am. Can you hear me?
Yep, please go ahead.
Yeah, so I'm Willem Schultens. I'm one of the clinical pharmacists at Carson Tahoe Hospital.
Thanks, Willem. All righty. Next is Krista.
Hi, I'm Krista Secord, nurse practitioner in a rural clinic in Elko.
Hi, Krista. Good to see you again. Tyson.
Hi, I'm Tyson McBride, physician assistant. Work with Dr. Van Gilder here in Lovelock, Virgin General Hospital.
Thanks, Tyson. Kristen Carmen, please go ahead. I'll take you off mute. Go ahead, Kristen.
Carmen from South Lyon Medical Center, and I also am in the DMD program at Over School of Nursing.
Thanks, Kristen. Jessica Murray. Jessie, are you there? Looks like she's chatting with somebody, so we'll move on.
I'm Jessie Murray, Boulder City Hospital, Boulder City, Nevada.
Thanks, Jessie. Next, somebody who's joined on their iPhone.
Hi, this is Beth Wilmer from the VA.
Hi, Beth.
We recognize the laugh.
And there's another folks joined on their iPhone. I've taken you off mute, so we should be able to hear you. Okay, maybe no audio there. So if you could actually just write in through the chat box and let us know who you are and where you work, that'd really help us. Maria?
Hi, my name is Maria Siddiqui. I am in Grand Prairie, Texas in family practice, and I'm doing the doctorate program at LMU.
Great, thanks. Good to have you. Carrie Jo?
Hi, I'm Carrie Jo, the MDRO prevention coordinator here at VA Reno, Nevada.
Thank you. Dr. Bayan?
Oh yeah, I'm David Bian, Ely, Nevada hospitalist.
Thanks, Dr. Bayan. And Matt Walker, CEO at William B. Ryder Hospital. Please go ahead.
Yeah, hey, Matt Walker. Yeah, over here in Ely as well. I'm also a pharmacist, so I like to go into these things and figure out what I'm missing.
Great to have you today, Matt. Thanks. And we had one other join us, Julie Ahmed. It looks like you haven't joined the audio yet, though, so just make sure you click that. Oh, it looks like you did call in. Julie, could you introduce yourself, please? Oh, just a second. Let me take you off mute. Go ahead. So Julie, it looks like you're joined by telephone. So it's *6 to unmute yourself, and we'll be able to hear you for introductions. A lot of folks joining us now. So I'll just write in through the chat, write something down there. It'll pop up as a little orange bubble. So if you could just write in your name, credential, and location for us, that'd be great. So I want to open it up as we do through ECHO and offer you all an opportunity to discuss your challenging patient cases or any questions or concerns that you have about your facility. So does anybody have anything they'd like to discuss with the team today? Feel free to unmute yourself with that microphone icon in the lower left corner or write in through that chat box.
No worries. We have some cases today that the residents will present.
Starts off with that article then.
Yeah, so, you know, if you've listened in over the years, we all go crazy trying to stop the treatment of asymptomatic bacteria, which is probably the greatest overuse of antibiotics. And we've talked over and over again. There's been new guidelines that came out, basically asymptomatic bacteria, if they ain't got symptoms, you don't treat it. That's the bottom line. And this article came out in the New York Times about 2 to 3 days ago. It's by a reporter. It's the most amazing summary of all the studies. Great. Talks about, you know, dementia doesn't cause it. Don't let yourself get treated. Don't take antibiotics. And I'm going to print it out and give it to patients who want antibiotics. And I just think you should read this and print it out and hand it out. We have a patient who's been driving me crazy. You know, every time she's got dementia, every time she gets confused, I get an emergency phone call. She's got a bladder infection, and I'm trying to wean them off that. And I was going to send them this article, but it's really, even though it's not written by a physician, it's really a remarkably good explanation of all the reasons why we should be testing urines and treating it. And like if you work at the VA, that's one of our listeners, some of our listeners, and that's been a big struggle to block the getting pre-clinic UAs and reflex cultures. And so this is a really nice article. We've all read it here. It's been really great. So Troy's going to send a link.
Yeah, so I sent the link out through the chat box, but if you don't see that chat or just want to follow up with me about it, you can email me. Easiest one is projectecho@med.unr.edu, and I'd be happy to share that with you. So just a couple announcements for us is this is our video disclaimer. So we do record all of these sessions and make them available online for anybody who's not joining us today to still be able to learn this material. So if you have any issue with being on video, let us know and we can edit you out and not make you famous. Next is our reminder, if you do present any patient cases, not to disclose any protected health information, no HIPAA violations here. So just please adhere to that if you do share a patient case. So go ahead.
I'll introduce the residents. Today, Marshall, Rena, and Esther Zhang, they're both PGY2 infectious diseases pharmacy residents at Renown. We asked them to put together just a quick, the new Community Acquired Pneumonia guidelines came out, or an update to them a couple of weeks ago, and so we've asked them to summarize those for us and have them tell us how it's going to change our practice, or at least confirm what we've been working and doing over the last several years. So take it away. All right.
Yeah, clickers for you.
So we have nothing to disclose. Learning objectives for the presentation. So given a patient case, employ the most appropriate therapy for outpatient community-acquired pneumonia. Based on patient-specific information, illustrate risk factors for drug-resistant pathogens and need for empiric broad-spectrum antibiotics. And then given patient cases, be able to employ the most appropriate therapy for inpatient non-severe CAP and inpatient severe CAP.
So just a little background, the guidelines were published in the beginning of this month, actually, so October of 2019, and it's a collaboration between IDSA and the American Thoracic Society. And some of the disclaimers in the guideline include the fact that these guidelines are for patients already diagnosed with radiographic evidence of pneumonia. They don't pertain to patients with recent foreign travel or patients who are immunocompromised. So pretty much just your run-of-the-mill community-acquired pneumonia patients. And this is a roadmap of some of the highlights that we're going to go over. So on the diagnostic side, we have new recommendations regarding blood and respiratory cultures only should be obtained in inpatient severe CAP or those infected with resistant organisms. For procalcitonin, please ignore them when you have radiographic evidence as well as clinical symptoms consistent with pneumonia when deciding whether to initiate treatment or not. On the treatment side, please avoid outpatient macrolide monotherapy due to the increased resistance for Streptococcus to macrolides. Please forget the term healthcare-associated pneumonia that was instituted in prior versions of the pneumonia guidelines. And finally, macrolides are preferred over doxycycline for the treatment of non-severe inpatient CAP treatment. So the very first recommendation is regarding sputum and blood cultures. So like I was mentioning earlier, please only obtain these in inpatients who have severe pneumonia as defined by this chart you see on the left. Essentially, the criteria for severe pneumonia include 1 major or 3 or more minor criteria. Essentially, these patients have an 84% sensitivity for being admitted into the ICU. So we're really talking about patients who are ICU material here. So for these patients, we would acquire blood and sputum cultures because the consequences of not treating the correct organism is much higher in these patients. We would also want to acquire sputum and blood cultures for patients with prior cultures with resistant organisms in the prior year, as well as who have received antibiotics in the past 90 days. So again, patients who are at higher risk for being infected with a resistant organism, or patients who are at risk for worse outcomes if we're not treating them correctly.
So for our first patient case, a 62-year-old female with a past medical history of COPD presents to the emergency department with a 2-day history of cough, shortness of breath, subjective fever, and chills. Her home medications include some inhalers for COPD. On physical exam, she's found to be febrile. She has a new oxygen requirement. She has diffuse wheezing and bronchi throughout. Chest x-ray is obtained.
So you can look on the right side over here, the diaphragm, you can see a nice different distance.
You can touch on there, Chairman. Sure.
So right over here, you can see the lungs, the ribs, and the diaphragm real nicely here. On the other side, on the left side, you see obscured. So that means that there's water in the lungs. And so you would say that's consistent with pneumonia because the lungs should be clear. On the left side, there's water or fluid in the lungs, and so the diaphragm is obscured. So you'd call that a patchy infiltrate in the left base, consistent with pneumonia.
So for our first question, the patient's procalcitonin comes back negative at less than 0.05. Based on the recommendations and the updated guidelines, should antibiotics be initiated for the patient?
Yeah, any input out there, feel free to write in through the chat, shake your head, yes or no.
And does anybody have procalcitonin readily available at your institutions, or is it a send out still?
Maybe give a little background on what procalcitonin is.
Sure, you want to do that? Or Kia?
Sure.
Go ahead.
So procalcitonin is a precursor for calcitonin. It is expressed in many cells in the body, particularly in the airways or the lung parenchyma, as well as the esophagus and so forth. Typically, we'll see rises in procalcitonin in the presence of a bacterial infection. In the presence of a viral infection, sorry, I'm forgetting the chemical that viruses release actually suppresses the release of procalcitonin. So we've historically been using this as a guide to see or to determine if a patient has a true bacterial process versus not. Typically, there are set cutoffs determining whether a bacterial infection is likely versus not. So if it's greater than 0.25 to 0.5, Continuing antibiotics is encouraged if it's greater than 0.5. They're highly encouraged if it's less than 0.25. Discontinuing antibiotics is highly encouraged.
So any thoughts on what would you do? Patient with cough, fever, and an infiltrating chest X-ray, but the procalcitonin is negative.
So based on the new guideline,
I think Dr. Bayan had something to say. Dr. Bayan, go ahead.
Okay. Yeah. Procalcitonin, my understanding is that we don't use it to make a diagnosis. For pneumonia, we use it to guide us when to stop antibiotics. If it was up to me, I would have go ahead and go through the initial course of antibiotic for a non-severe community acquired pneumonia.
Great, and yeah, that's actually the updated guidelines recommend not withholding antibiotics in the presence of clinical symptoms and a positive radiograph showing pneumonia. So you would go ahead and start antibiotics even though the procal is negative. And the reason they recommended this was when they looked at the studies, there was a wide range of specificity for procalcitonin, and the studies didn't always restrict the inclusion criteria to just patients that had a positive chest X-ray. And then Esther will go a little more into it.
So just to reinforce basically what Marshall said, for the initiation of treatment, due to the wide range of sensitivity for the procalcitonin test to pick up a bacterial pneumonia, it's actually not recommended to rely solely on a procalcitonin when deciding whether you want to initiate treatment or not. On the other hand, if you're thinking about stopping antibiotic treatment, it can be used as a tool to stop antibiotics. For example, if there's an 80% decrease from the peak procalcitonin value, or if the value falls less than 0.25, then you can sort of use it as a marker that the patient is achieving some level of clinical stability and use it to limit treatment to the guideline concordant duration of 5 days or 7 days for resistant organisms. So now we're going to start going into the treatment portion of the guideline update, and we'll start with outpatient therapy. Essentially, for somebody who is otherwise healthy without some of the comorbidities listed below, the first-line treatment option involves amoxicillin or doxycycline or macrolide, and all of these are monotherapy. However, you notice that macrolides are only recommended if the local pneumococcal resistance is less than 25%, and I will elaborate on that a little bit later. But for now, and just know that if somebody who walks in is otherwise healthy and is fairly young and has a walking pneumonia, doxycycline is probably preferred just to cover your atypical organisms as well as Streptococcus. On the other hand, if you have somebody who has community acquired pneumonia who is fit for outpatient treatment, but they do have comorbidities including chronic heart disease, lung disease, liver disease, kidney failure, diabetes, alcoholism, malignancy, or asplenia, then these patients are actually at a higher risk for being infected with a resistant organism due to frequent healthcare contact, or they're at an increased risk for worse outcomes if we're not treating them correctly. As a result, we actually recommend dual therapy or a combination therapy with a beta-lactam such as augmentin or cephalosporin, as well as macrolide or doxycycline. Or we can use a monotherapy with the respiratory fluoroquinolones. So this is what I was alluding to earlier. The guidelines do recommend macrolide outpatient monotherapy if the rate of resistance is less than 25%. But as you can see on this map, there is not a single geographic region on that map in the United States that has resistance rate under 25%. And where I am at in Nevada, the rate is actually the lowest all across the map, and that's at 31%. So really, you shouldn't be using macrolides such as azithromycin as monotherapy in the outpatient treatment of community-acquired pneumonia.
The Z-Pack.
The Z-Pack, exactly, right.
It's easy to write for, but it's not a good choice.
Z-Pack as directed.
So for our next patient case, a 40-year-old male presents to the emergency department in September with a 3-day history of fever, chills, cough, shortness of breath, sputum production, and right-sided chest pain. They are a smoker. They don't have any home medications. On physical exam, they're a little tachycardic. They have a new oxygen requirement, decreased breath sounds and rales. Their labs show a leukocytosis.
So on the chest X-ray, anybody want to read it for us?
It's got a red circle.
So if you compare it to our last x-ray where we saw a little patchy infiltrate, you can see on the right upper lobe, what we call a lobar, the right upper lobe. So it's a nice line there with a fissure between the right upper and the right lower lobe. And it's consolidation, so it's a dense lobar infiltration. So this would be called a lobar pneumonia. And it's most typically seen with, like, what bacteria would most likely cause a lobar pneumonia? Anybody?
Strep pneumonia.
Yeah, so strep, you don't even have to talk to the patient. This guy's got most likely strep pneumonia. But it's a nice, dense consolidation localized to one lobe of the lung.
So this patient is admitted to the hospital and they are admitted to the general medicine floor. Which of the following is an appropriate initial treatment regimen?
You want to go through each one and ask what people think?
So who thinks ciprofloxacin 400 milligrams IV twice a day?
Or what's wrong with it?
Or what's wrong with it?
It's too aggressive, right?
For that, yeah, well.
Penetration.
Sorry, what was that, Dr. Boyan?
Doesn't cover strep.
Oh, sorry.
He said penetration. Go ahead.
So with ciprofloxacin, so when you use the fluoroquinolone as monotherapy, we usually use one of the respiratory fluoroquinolones, and they are called that because they cover for pneumococcus or Streptococcus pneumoniae, and ciprofloxacin doesn't have reliable coverage against it. So who thinks for the piperacillin, tazobactam, and vancomycin? No one. And so for that one, this patient doesn't have any risk factors for drug-resistant organisms, so that would be too broad for our patient. How about azithromycin and ceftriaxone? Yeah. And that would be appropriate therapy with a macrolide and a beta-lactam. The patient doesn't have any risk factors for drug-resistant organisms. And then the last choice, ceftriaxone and metronidazole. There's no coverage for atypical organisms. The metronidazole is for anaerobes, which in the new guidelines, they don't recommend routinely adding extra anaerobic coverage with metronidazole unless you suspect an abscess or empyema.
I have a question.
Yeah.
Since I've been out of this for 3 years or more. The azithromycin, we used to start that, but then stop it because we knew that it wasn't an atypical. What do they talk about that? I mean, all you need is the ceftriaxone, but I know the recommendation is the combination. But they talk about stopping the azithromycin or not?
They didn't talk about stopping it. They talked about how they looked at studies, and there may have been some evidence. A lot of it was in severe pneumonia, but there may be a mortality benefit with the combo of the macrolide and the
Empirically.
Yeah.
Empirically. Once it's confirmed, there were some old studies that, and I'm not aware of anything new, so if anybody else knows anything, please let us know, but older studies that were retrospective in nature and more subgroup analyses that found there was a mortality benefit if you continued the azithromycin with the beta-lactam even after you isolate pneumococcus. But I don't know if that's ever been demonstrated at prospectively.
Yeah, that's
better design.
I remember those studies, but they were still.
Yeah, I don't think there's anything new on it, and I don't think they don't specifically address. I don't remember in the guidelines this one if you should continue it or not.
I didn't see anything.
I'm just curious.
Yeah, it all comes up often still, the discussion on whether or not we should continue it.
And then for this patient, since they're just admitted to the general medicine floor, they're not intubated, they're not on pressors, should we get blood cultures and a sputum culture for this patient?
They don't have any of the major criteria, right? So do they have any of the minor criteria?
No, they'd be classified as not severe, so we don't need any, the guidelines don't recommend getting cultures for them, because it won't change the course.
So that's a big change. They used to say you better culture, you better get blood cultures. I mean, why didn't you get blood cultures? But the guidelines say forget about it.
Yeah, there's probably a lot of lab stewardship opportunities with the blood and sputum cultures.
Did they recommend any the urine tests for?
No, it's not all that crap out.
Okay. I'm way back in
This sounds like an outbreak or something.
So last year.
You're 2007 old, the last guidelines.
All right. Is that all right?
No.
Oh, there we go.
Okay, so it sounds like you guys already know what the treatment, or at least the preferred regimen for non-severe inpatient CAP is without Pseudomonas or MRSA risk factors, but I'll just kind of go over them again. The first line, there are two options. The first of which is a combination therapy of beta-lactam plus a macrolide, and that can be unison or ceftriaxone plus zithromycin, just an example. And the other first line is monotherapy with a fluoroquinolone. Not personally preferred, but it is listed as a first line treatment option. And for whatever reason, if your patient has contraindications to both of these first line regimens, then a beta-lactam and doxycycline is also available, but with less evidence to it.
So then this was just you guys nailed it on the last time. We already talked about why the other ones weren't the appropriate choice.
And then swinging into the end of severe inpatient treatment, again, without Pseudomonas or MRSA risk factors. And just to reiterate, severe means one major or three or more minor criteria. So the treatment options they all include a beta-lactam backbone, but you can add either a macrolide or a respiratory fluoroquinolone to it. And you notice that doxycycline is actually not recommended at all for severe inpatient treatment. And again, this is due to the greater mortality benefits seen with the macrolides.
So it's basically the same regimen for non-severe, right?
Essentially, but with the doxycycline removed.
Okay.
It's not even as an alternative.
Yes.
Right.
Okay.
And then another update the guideline had was that they want to do away with the term healthcare associated pneumonia altogether. So in the old days, that included patients, for example, residing in a long-term care facility, who had home wound care, who are on hemodialysis. It was found that these characteristics actually do not accurately predict patients who will be infected with a resistant organism. So instead, what we have now is CAP with risk factors for MRSA or Pseudomonas. And this slide actually lists the recommendations for what to do if you do find those risk factors in a patient, but this is very, very complex. So what I'm going to do is actually talk about the next slide, which simplifies it a little bit. So essentially what the guidelines say is that if a patient had prior respiratory cultures positive for MRSA or Pseudomonas, and Pseudomonas here refers to any resistant gram-negative organism within the past year, then you should cover for that organism. However, if a patient has severe community-acquired pneumonia and also received IV antibiotics within the past 90 days, then you should also cover for resistant organism. So that is one step above for the patients with severe pneumonia. Because if you had received IV antibiotics within the past 90 days and do not have severe pneumonia, you do not need to be covered for resistant organisms. You only need to get cultures to rule out infection with resistant organisms. And as always, if you are going to start somebody on broad spectrum empirical antibiotics, obtain cultures, respiratory cultures, blood cultures, plus or minus nasal PCR if you're treating for MRSA, so that you have the opportunity to de-escalate therapy at 48 hours if you don't find MRSA or resistant gram-negative organisms.
Can I just say something? So we see a lot of people, like they're on the floor on Rocephin and Azithro, but they're extremely sick because they have underlying COPD, and they get vancomycin. The point is that these patients who are extremely sick with community-acquired pneumonia, if they don't have risk factors, still do the Rocephin and Azithro. You don't need to do the vancomycin. You don't need to do the Zosyn. Look at them. Have they been on antibiotics? Have they been? But if just come in the hospital, and, community-acquired pneumonia without risk factors, even in the ICU, the regimen is still the Rocephin and Azithro or the fluoroquinolone. You don't have to upregulate to some broad spectrum coverage unless they have these risk factors. Okay, so it's the risk factors which are important, not how sick the patient is. And I think that's a big change, and it'd be very helpful.
It is how, yeah.
One of the problems that I see with that is that until you can come in, somebody fairly healthy can come in with a staph pneumonia,
right,
and go to the ICU, and I would think you would cover that initially until you rule that out. I can understand not having Pseudomonas, but
They don't particularly discuss MRSA as a, would cover for MSSA, I mean, with the ceftriaxone, but on a case-by-case basis, like post-influenza pneumonia. I don't think they specifically address MRSA coverage, do they, in a severe pneumonia without risk factors? No. But what we would do in our practice is weigh it on a case-by-case basis. If we knew they were a post-influenza pneumonia, we may be more inclined to cover MRSA in that severely ill ICU patient with CAP. But it's on a case-by-case basis, and they don't address that specifically in the guidelines. I think the other thing, what I liked about these is that for the non-severe patient with risk factors for resistance, they really recognize that room for error. They may be colonized with a resistant organism, but it's unlikely to be caused of the actual infection because those resistant gram-negatives and MRSA tend to cause more severe pneumonias. And if you do happen to miss them up front, you again have room for error, and you can always cover them on the back end once you get your cultures back. The other thing that these guidelines do a great job of is, recognized for the first time, is the role of MRSA Neri swabs with de-escalation of antibiotics. And then they also go on to say that you shouldn't necessarily escalate antibiotics based off the Neri's PCR because the positive predictive value is not as good as that negative predictive value, which is 90+%. And so I don't know if any facilities are using MRSA Neri swabs to assist with de-escalation, but if you have the capability, I highly recommend it.
And then, as alluded to earlier, aspiration pneumonia, to cover or not to cover, we're really talking about anaerobic coverage here. And the guidelines do not recommend adding anaerobic coverage with therapies like metronidazole, unless you suspect that the patient may have a lung abscess or emphysema. And this is because trials have shown that anaerobes actually don't play a large part in aspiration pneumonia.
So for our next patient case, a 55-year-old female with poorly controlled diabetes and recent flu symptoms presents to the emergency department septic with a 2-day history of progressive fatigue, cough, and shortness of breath. She was recently hospitalized out of state where she was treated with IV antibiotics for pneumonia. Her last A1C was 12.9. Home medications include some diabetes medications along with medications for cholesterol and antihypertensives. On physical exam, she's found to have a low-grade fever. She's got hypotension. She's tachycardic, tachypnic, 82% oxygen saturation on room air. She's got decreased air movement in all lung fields. Her labs show a leukocytosis, an elevated lactic acid, and a positive procal at 0.8. Her respiratory status worsens. She's intubated. She's on pressors, and she's admitted to the ICU.
So even before you talk about that, what would you be considering antibiotics for a lady who's had IV antibiotics in the last few weeks, right? So that would raise a red flag following the guidelines. So her x-ray is, remember we just saw the lobar pneumonia with the pneumococcus. Now we see bilateral infiltrates not localized to the lobes. And you can see an arrow. It looks like it's circling a cavity on both sides. So you would say this is a very multilobar pneumonia, diffuse multilobar, with it's not the dense infiltrate, but it's got looking like cavitary area. So you'd be very concerned about what bacteria in this lady. And this is the CT scan shows you, those are called air bronchograms, where you have the consolidation of the lungs. They outline the bronchus. So you see these nice outlining of the air coming through the bronchus into the lobes. But you also see, like over here, almost looks like there could be a cavity there, there could be cavity here. So this is a multilobar infiltrate with cavities. And cavities are not typically seen in pneumococcus, so you'd be thinking about other bugs besides that. So what regimen would you guys go through once you go through the choices?
And then so the first regimen, piperacillin tazobactam plus azithromycin plus vancomycin plus oseltamivir. Who thinks that would be an appropriate regimen?
I'm reading all the other ones before I commit.
I'll give you guys a second to look them over. So
had she had her flu treated previously, or was it just or
Just flu symptoms.
flu symptoms?
And why would you guys want to go with this regimen? What in her history would make you concerned about this regimen?
Raise your hand.
So the septic shock that she's in, recent flu-like symptoms, I have to, I mean, just right after having the flu, I would assume if you have a post-influenza pneumonia, I'm thinking strep or MRSA. With that chest x-ray, I'm thinking MRSA. She has risk factors for resistant organisms. So per the guidelines, we would go with the SOS and Banco. The flu-like symptoms, we would start with oseltamivir until proven otherwise, and then atypical coverage per the guidelines.
And her recent IV antibiotic.
And the recent IV antibiotics.
Yeah, so she's classified as severe pneumonia because she's in the ICU, she's on pressor, she's intubated, and she's had the recent IV antibiotic use. So we would cover empirically with piperacillin, tazobactam, and vancomycin for MRSA and Pseudomonas. The second choice, ciprofloxacin, ceftazidime, oseltamivir. That one, while it is a fluoroquinolone, ciprofloxacin and ceftazidime, neither of them provide good coverage for pneumococcus, which you always want to cover for in pneumonia. For the third choice, ceftriaxone, azithromycin, oseltamivir. For that one, we're not covered. She's a severe pneumonia with recent IV antibiotic use in the last 90 days, so we want to make sure and cover for possible drug-resistant organisms such as MRSA or Pseudomonas, and that one does not provide coverage for it. That would be more for without risk factors for drug-resistant organisms. And then for the last choice, cefepime plus vancomycin plus metronidazole plus oseltamivir. The addition of anaerobic coverage isn't recommended unless there's evidence of empyema or an abscess, and there is no atypical coverage with that regimen.
But couldn't those cavitaries be an abscess?
Down the line at some point to become abscesses.
I mean, so
Yeah, I think it's a great question. I think it would be if somebody added it, I don't know if I would argue with it, but I mean, you're the one that taught me
A is
that
number one, but D is
in
not
anaerobic lung abscess is usually not the septic shock patient too. So
You're correct.
And Zosym gives you the same anaerobic activity anyways.
Oh yeah.
That's true.
And this is a patient that you'd want to culture up the wazoo, blood, sputum, everything. So this is one you definitely want to culture.
Sending flu PCR for sure.
Yes.
And then the final update for how long. So you have to decide when do you want to take away the antibiotics. The guidelines say no less than a total of 5 days, although most patients actually achieve clinical stability within 48 to 72 hours. So for whatever reason, if the patient doesn't achieve that within 5 days, you should probably be thinking about some other complications of pneumonia, such as the lung abscess or empyema, or even maybe an alternative source of infection. However, if you're treating for resistant organisms such as MRSA or Pseudomonas, the guidelines do say to extend out that duration out to 7 days. And the chart here just lists some of the criteria the patient has to meet for clinical stability, and it's the exact same chart as the previous version of the guidelines. Essentially, achieving stable vitals, be able to have oral intake, returning to a baseline level of mental status. And once you're done with treatment, don't look again. Don't repeat chest x-ray if the patient's symptoms has resolved and you're not thinking that the patient has complications.
So cough is not on there, just to point that out. So cough is not a symptom that you're looking at to resolve within that 5-day time frame.
And then in summary, I'll just go over some of the highlights we've already talked about. So number one, only obtain blood and sputum cultures in severe inpatient CAP patients or those patients you suspect may have been infected with a resistant organism. Please ignore procalcitonin when you're thinking about starting therapy if you have radiographic as well as clinical evidence that the patient has community-acquired pneumonia, but you can use it to make decisions regarding the discontinuation of therapy. Please avoid macrolide monotherapy for outpatient treatment because of the increasing rates of streptococcal resistance to macrolides. So please forget about the previous term of healthcare-associated pneumonia and think about prior respiratory culture with MRSA or resistant gram-negative organisms within the past year, or for severe patients, previous treatment with IV antibiotics in the 90 days preceding the CAP. And finally, macrolides are recommended over doxycycline in non-severe inpatient treatment. However, if the patient has severe pneumonia, macrolide is actually not guideline recommended. Did you say that right?
Doxycycline.
Sorry, doxycycline is not recommended. Yep, good catch.
When would you check procalcitonin if you're thinking about de-escalating? Like, what would be a time frame for checking that?
Usually we stop if there's a 80% decrease in peak or less than 0.25. But then if the patient is clinically stable and you think that the infection is resolving and you don't have a baseline, that's probably when you would check it around day 3 through 5, I would imagine.
Okay, thanks.
So it has a 24-hour half-life, so you'd expect that it would decrease by 50% if you're on appropriate coverage every day. So as far as checking it, like at our hospital, we'll do it at baseline. We'll start antibiotics if we truly believe they're infected, and then we do Q48 for 3 readings. And then depending on that, we'll decide to de-escalate or not.
Jessica, what's your comment? She's had an antibiotic program. How do you think this will change what we see at our hospital?
Not a whole lot. I mean, we've been, like, our pneumonia order sets are very consistent with this. I think it's always been a difficult discussion to get rid of the anaerobic coverage in anybody that aspirated stroke patient, whether or not it was a legitimate aspiration or not. This is additional ammunition to have that discussion and say that, look, I'm not the only one saying you don't need this flagell. That's probably the biggest. What else do you think? We have some physicians that very much prefer doxycycline, and it is a more costly antibiotic than azithromycin. So from a cost perspective, this is again more ammunition to use azithromycin over doxy as long as there's no QT prolongation.
While probably not beneficial for our hospital in the sense that we treat most pneumonias for 5 days, other hospitals that are doing extended courses, hopefully this will help reduce those durations as well, just basing that off the guidelines.
So in the severe patient, with the azithromycin, okay, why exactly are you adding that? I mean, it's very unlikely they have a atypical pneumonia, okay? So are you adding it for the combination that seems to be better outcomes with mortality?
I think it's the mortality benefit, but I have the same questions as you. Is it because, but why is that outcome improved? Is it, are we missing some Legionella cases if we don't, because we're not testing for it? Yeah.
Well, Legionella, yeah, definitely can put you in the hospital.
Right, and so,
in the ICU.
But beyond that, I'm not sure. Yeah. Does anybody else see that this will change their practice at all? Just out of curiosity. Or any ideas on that other people can share?
Yeah, feel free to unmute yourself, share your thoughts, your comments.
Oh, and the removal of like sputum and blood cultures is routine in non-ICU patients would be another.
I guess the obvious too is the lack of the HCAT definition. Now that it's published that we're not using that term anymore, I think that'll really benefit a lot of prescribing habits upon admission.
Yeah. Basically, is it HCAT? It's CAP.
Yeah.
And then I ask myself, does this patient have risk factors for resistance? Has he been on antibiotics? Does he have MRSA or a history of Pseudomonas or other resistance? And just no matter how sick they are, if they have those risk factors, I just treat them for regular pneumonia. If I worry about the other ones, I throw in the vancomycin.
Yeah.
Instead of just, the patient's sick, let's do vancomycin.
Yeah.
Right. So I think it helps clarify in your head how to think about your patients.
Yeah, right. That's the other big thing. If you were treating HCAP as a hospital-acquired pneumonia with vancomycin, this is a huge opportunity to cut that usage back and no longer call it HCAP.
Yeah, just pneumonia plus or minus risk factors.
Oh, when I rounded with Jessica and Dr. Krasner, we had this thing we called bad bug, bad disease. And so if somebody was in the floor but not in the ICU, and even if they got a pneumonia on the floor but stayed on the floor, we wouldn't necessarily cover Pseudomonas or vancomycin specifically because
You got a bad bug, you're gonna be sick as a dog,
Right.
okay?
And that was
MRSA pneumonia, you ain't gonna be walking around the floor pushing your oxygen tank.
yeah, or you're probably not going to be on the floor.
Yeah.
If you're on the floor, it's on the floor.
Anna just shared a comment. I will still have a challenge convincing my patients that their cough is not a basis for continued antibiotic treatment.
Yes. We
Blame it on
agree.
us.
Yeah.
So we'll wrap up. We are just about at time. I want to do a quick poll though. Have you reviewed the learning objectives for today to see if we met those for you and if you were satisfied with the presentation for today? As well as I want to make a quick announcement about our next session, which is going to be on November 21st, noon to 1, or 12:15 to 1, same time, same place, same Zoom link and everything like that. So we hope you'll join us then. Please, in the meantime, feel free to reach out to me. We'd love to hear your cases and your issues that you're facing out at your facility. So contact me with those and we'd be happy to help you.
And the other thing is the program is setting up their own ECHO program. Feel free to contact us. We'll be happy to talk to you about, 7 years of what works and what doesn't work.
Absolutely.
And we've done over 100 of these. So
yeah.
Thanks everybody for participating.
Yeah, thanks everybody today.
Thanks.
Thank you.
Thank you.
Thank you.
Thank you.
Take care.
Thanks everybody.